So first of all, let's look at the sensory supply to the hand. So the ulnar nerve, and the ulnar nerve, if we remember, is C8 and T1, so it's the lower part of the brachial plexus, and that innervates the ulnar border of the hand. So if you think about we call it the medial side because the anatomical position is with the palm facing forwards. It's the medial border, and so the ulnar nerve innervates the sensory supply of the medial 1.5 fingers, the little finger and half of the ring finger. The median nerve is responsible for the rest of the palm, and on the back of the hand it's responsible for the tips of the other fingers. The radial nerve has a small area on the palm, usually just at the base of the thumb, and then it has a large part of the back of the hand up to the proximal interphalangeal joints, and excluding the area that's handled by the ulnar nerve. So those are the sensory areas in the hand. One of the things that can affect nervous function in that hand is carpal tunnel syndrome. So I just want to talk about, first of all, about the carpal tunnel. The carpal tunnel consists of the bones of the distal row of the carpus and covered over on the anterior surface by the flexor retinaculum. And through the tunnel run 9 tendons and 1 nerve. The 9 tendons, 4 tendons of flexor digitorum profundus, 4 tendons of flexor digitorum superficialis, and flexor pollicis longus, the long flexor of the thumb, and also the median nerve. So here's a picture of it. So here is the flexor retinaculum. Now this is a strong band that closes off the tunnel anteriorly and closes between the hook of the hamate across to the trapezium. And that encloses the space behind it, and that is the carpal tunnel within which these tendons can move up and down, and the nerve is there. So just to go over again the 9 tendons, there's flexor pollicis longus on the thumb side, and then at the front we've got flexor digitorum superficialis, and at the back we've got flexor digitorum profundus tendons, 4 of each. So those are our 9 tendons, and our nerve is the median nerve there. And there's not a lot of spare space in the carpal tunnel. So if there's any swelling there, for example from an inflammatory arthritis involving any of the bones, or just from edema, hypothyroidism, a whole range of things can cause fluid and inflammation in this area, then the pressure within the carpal tunnel rises. And this produces pressure on the median nerve and causes dysfunction in the median nerve sensory supply. And so it causes dysfunction in the index finger and middle finger and part of the ring finger. So that's carpal tunnel syndrome. If it's very severe, it can also affect the motor function of the median nerve, which we'll come to, which is primarily the thenar eminence and the lateral 2 lumbricals. Okay. Now, one other thing that can come up in exam questions about carpal tunnel syndrome is that one branch of the median nerve leaves the median nerve. So here's our median nerve here, entering the carpal tunnel behind the flexor retinaculum. And one little small branch called the palmar cutaneous branch of the median nerve actually comes superficial to the flexor retinaculum, so is not affected by carpal tunnel syndrome. So someone with carpal tunnel syndrome may well have an area of preserved sensation in the palm, despite having a loss of sensation more distally. Okay, let's move on to the innervation of the muscles of the hand. We need to think about those in 4 groups. There's the thenar muscles, those are the muscles on the thumb side. The hypothenar muscles, those are the ones on the little finger side. The interossei, the muscles between the fingers, and then the lumbricals, small 4 funny little muscles which we're going to come to. So here's an image of the muscles of the hand. So we've got the thenar eminence on the thumb side, the hypothenar eminence on the opposite side. We've got 2 sets of interossei, a dorsal set and a palmar set, and then we've got the lumbricals. Okay. So let's first of all focus on the thenar eminence. Well, both the thenar and hypothenar eminences both have three muscles. There's an abductor, an opponens, and a flexor in each. And we're going to look at those in a moment. So those are the muscles. And so I'm going to just play a short video which is going to go over these muscles. When considering the innervation of the small muscles, the intrinsic muscles of the hand, there are four groups of muscles to consider. First of all, there's the thenar group of muscles. So if we look on the right hand side of this image, we've got the thumb, and the first of these is the opponens pollicis. The opponens because it opposes, it brings the thumb across the palm to meet the other fingers, and it acts on the metacarpal, and it arises from the distal row of the carpal bones and the flexor retinaculum. So that's opponens pollicis. Just medial to that is flexor pollicis brevis, which attaches to the proximal phalanx, so it attaches more distally to the opponens. And then superficial to those two is the abductor pollicis brevis. So that's your thenar eminence made up of an opponens, a flexor, and an abductor. And they are all innervated by the median nerve. The next muscles innervated by the median nerve are the lumbricals, and they're a little bit unusual. So the lumbricals actually don't arise from bone. In fact, they don't start or end on bone. They arise from the tendons of flexor digitorum profundus. Two layers of flexor tendons, of course, deep and superficial. Here's the deep layer, and the lumbricals arise from the tendons, and they wrap round behind the finger to the dorsum of the finger and insert into the extensor expansion. And what the lumbricals do is they bend the metacarpophalangeal joint, but at the same time they put tension into the extensor mechanism and so extend the interphalangeal joints, so the proximal and distal interphalangeal joints. So that's the lumbrical. There's one, and there's the next one, and those are also, the two lateral lumbricals are also median nerve innervated. There are two other lumbricals for the other two tendons, and they are innervated by the ulnar nerve in common with the hypothenar eminence. So if we just take those away, to match our thenar eminence, flexor, opponens, and abductor, on the hypothenar side we have the same: an opponens, a flexor, and an abductor. And in addition, the other muscles innervated by the ulnar nerve are the interossei. And there's two rows of those. There's a palmar row and there's a dorsal row. And they arise from the metacarpals and insert into the proximal phalanges, the base of those. And those are the muscles that make the fingers spread wide and move together again. And those are ulnar innervated. And that's why we use this particular test as a test of the ulnar nerve. We get a patient to hold a piece of paper between the fingers, because in doing so they're using their interossei. And that's a test of ulnar nerve function. So I've only shown a couple of muscles there, but there's a palmar and a dorsal set, and I don't think we need to go into the detail of those, but those are also ulnar innervated. So I've gone over there the innervation of the median nerve, the thenar eminence, and the lateral two lumbricals, and the ulnar nerve being responsible for everything else. And that we use the median nerve and ulnar nerve innervation in the hands as ways of testing those two particular nerves. So when we want to test the median nerve, we put the hand flat on the table and ask the patient to point their thumb up towards the ceiling, to point it upwards. And in doing so, they're using abductor pollicis brevis, which is median innervated. And when we want to test the ulnar nerve, we put paper between the fingers and squeeze the fingers together, and that uses the interossei, which are ulnar nerve innervated. Okay, So as I've said, the hypothenar eminence is a mirror image of the thenar eminence in terms of its muscles, an abductor, an opponens and a flexor. They have rather long names because they're of the small finger, the little finger, which is the digiti minimi, so it's abductor digiti minimi, opponens digiti minimi and flexor digiti minimi brevis, because of there's also of course the long flexors of the little finger, the profundus and the superficialis. Okay, so those are the muscles in the hand. Let's just look a little bit more detail into the nerves in the hand and where they travel. So the nerves to the digits, the digital nerves, arise from the median and the ulnar nerve in this way. So here we've got the median nerve in the center and the ulnar nerve on the ulnar border, and they branch within the palm, ending up with a digital nerve running down each finger, more or less on the lateral side of each finger. So you've got 3 branches that come off the ulnar nerve, the little finger and part of the ring finger, and then you've got these other branches that all come off the median nerve. And if we have a look here, this is a section through a finger taken proximal to the proximal interphalangeal joint. So it's in the first part of a finger. And let's look at the structures here. So first of all, here's the phalanx, the bone in the middle. Over the top, this sort of grey arch, this is the extensor tendon. The extensor tendon at this point is like an expansion. It's a wide aponeurosis. On the other side, in the palmar side, we've got the flexor tendons, the profunda tendons and the superficialis tendons, the two slips from the superficialis tendon heading off towards the base of the middle phalanx. And that's surrounded by the flexor sheath, and we'll come back to the flexor sheath later. We've got the digital arteries on each side, and then finally we've got a digital nerve on each side. So this is the nerve that we're going to anesthetize when we put in a ring block. So when we put a ring block in, we put a needle through, usually from the dorsum of the hand through the finger, and we infiltrate right through either side of the finger in order to produce an anesthesia of the more distal part of the finger. Okay, so that's all I'm going to cover in upper limb anatomy 1 and that part of upper limb anatomy 2 of the neurological function. And let's move on now to some other aspects and going back up to the shoulder and looking at joints and ligaments and movement. First of all, this little diagram here is of the sternoclavicular joints, because we need to the curriculum includes these, and we need to know a little bit about these joints. So here we've got the sternum in the middle, and we've got a clavicle on each side and a first rib on each side. And on the right hand side you can see without the ligaments, and so there's a cartilage that sits between the end of the clavicle and the sternum, and then of course there's also the costal cartilage between the first rib and the sternum, or the manubrium in fact of the sternum. On the other side I've shown the ligaments that cross those, and so essentially the strength of the sternoclavicular joints, the stability of them, comes from these ligaments that cross between the end of the clavicle and the sternum, and of course you've also got ligaments with each of the ribs as well. So those ligaments are essential for the stability of the sternoclavicular joint. If we go to the other end of the clavicle, we've got the acromioclavicular joints. And these are important because they can be injured in falls onto the shoulder. So if somebody falls on the shoulder, there can be a downward force on the acromion. Here's the acromion here. So let's put some names in. We've got the clavicle here, we've got the acromion there, and down here we've got the coracoid process. So the acromion and the coracoid process are both parts of the scapula. And then let's look at the ligaments. So you've got from the distal part of the clavicle to the acromion, you've got the acromioclavicular ligaments. From the clavicle to the coracoid, you've got the coracoclavicular ligaments. And you've also got some ligaments that run between the coracoid and the acromion, known as the coracoacromial ligaments. Now, just leaving those aside for the moment, I just want to focus on the first 2 sets. These are the ones that are injured if somebody falls on the point of the shoulder and causes disruption to ligaments. So the mildest form is only a tear of the acromioclavicular ligaments, and it may only be partial tear, so there's no displacement, and that's known as a grade 1. If those ligaments are completely torn through, it's a grade 2, and the end of the clavicle pops up a bit, but is still bound to the coracoid process by the coracoclavicular ligaments. In a grade 3, the coracoclavicular ligaments are also torn through, and the clavicle pops up and is well separated from the acromion, and very noticeably there's a step. So those are the acromioclavicular ligaments, which are important in stability of the shoulder. If you notice in that last picture, we looked at the acromion process and the coracoid process, and these ligaments that span between them, the coracoacromial ligaments. Now, these ligaments, of course, run between two parts of the same bone, so there's no movement there between those two. And effectively, the acromion, which is like a shelf, those ligaments and the coracoid process, those structures together form an arch, the coracoacromial arch, over the top of the shoulder joint, the glenohumeral joint, and provide some protection to the joint from above. If we look at the shoulder with the shoulder cut open, if we imagine that we were able to cut open a shoulder joint and look at it, and so on the right hand side here we've got the head of the humerus, and on the left hand side we've got the shoulder. So this is essentially if we were looking into someone's left shoulder. So the anterior part of the person is to the left and the posterior is to the right. So let's just go over some of the structures that we've got here. Well, here we've got the glenoid, so part of the scapula, the central part of the socket. Here we've got the capsule, which we've cut open, the capsule that continues on both the scapula and the humeral sides. Here we've got something called the labrum. So the bony part of the socket is quite small, but it's continued as a plate of cartilage known as the labrum, and that helps to form a cup for the head of the humerus. And the labrum and the glenoid, where they meet, are sites of injury. It's not unusual to get what are known as labral tears, where the labrum comes away from the glenoid, particularly in sportsmen. Then let's look at a series of muscles, and we're going to be talking quite a bit about these muscles, and they're quite important in the function of the shoulder. Anteriorly, we've got subscapularis, and we're going to be looking at that again. Posteriorly, the lowermost muscle is teres minor. The one above that is infraspinatus, and the one above that is supraspinatus. And all these muscles come from the scapula, and they go across the joint and join on to the head of the humerus and bind the humerus into its correct position. This band that's running through here, at the top here, this is the long head of biceps, and it actually comes through the joint and attaches just at the top of the glenoid. That's the long head of biceps. Up the top here, we've got the shelf of the acromion and the coracoid process here, and the coracoacromial ligament that we talked about, providing some protection from above. So that's the glenohumeral joint. So let's look at these muscles around the joint in more detail, and these are what are known as the rotator cuff. Rotator because they're important in shoulder rotation. The shoulder has a vast range of movement. It's got a great deal of freedom of movement, very extensively, vertically, anteriorly, posteriorly, and so on, internal and external rotation. And this is accomplished because it has soft tissues around it. It has the capsule around it, and then it has these four muscles that are important in binding the head of the humerus to the scapula and in providing stability and strength and movement. So if we look from the front, if we imagine we're looking through the rib cage, and here we see the scapula through the rib cage, and there's this muscle in front of the scapula called subscapularis, very flat muscle which inserts by a wide tendon onto the head of the humerus. Then just above that is supraspinatus, and we'll look at that again, and that's really on the posterior side. So here we are looking at the shoulder from behind, and we see these other three muscles. The largest one in the center is the infraspinatus, attaching to the head of the humerus, which is below. It's called infraspinatus because it's below the spine. Here's the spine of the scapula, this ridge of bone that ends as the acromion. Infraspinatus is below that, and supraspinatus is above it. And you can see the supraspinatus appearing here and attaching on the top of the humerus, very important in abduction. And then the last of the muscles, these rotator cuff muscles, is the smaller one here, teres minor. So I'm just going to play another short video which just goes over these muscles and talks a bit more about their function. If we look at the back of the shoulder, here's the triceps, so called because it has three heads, the long head arising from the edge of the scapula, but then the other two heads, the medial and lateral heads, arising from the back of the humerus. And its action really is at elbow level, and we'll talk about it with respect to the elbow, innervated by the radial nerve. Here's the latissimus dorsi on its way up to the medial aspect of the humerus. Here's teres major, which is also an adductor of the shoulder and forms part of the back of the axilla. Now we're going to look at the rotator cuff muscles. Here's supraspinatus, which is one of the abductors of the shoulder, responsible for the first 10 to 15 degrees of abduction. Then below that we've got infraspinatus, which is another part of the rotator cuff and is an external rotator, the most important external rotator of the shoulder. And then finally, from this view, we've got teres minor, last part of the rotator cuff. The other muscle of the rotator cuff that we don't see from this view is subscapularis, which attaches to the other side, the anterior part of the humerus. Having talked about the muscles around the shoulder, if we just look at how they attach to the humerus. Here we are looking at the left humerus from the front, and we can imagine it attaching to the scapula. First of all, looking at the process of abduction. This is initiated by supraspinatus, so with the black arrow here indicates the pull of supraspinatus attached just at the top here. So supraspinatus begins the first 10-15 degrees or so of movement. And then once we get to about 20 or 30 degrees, the deltoid has much more powerful action and picks up the abduction of the humerus from its attachment much further down the humeral shaft, so it has much more rotational power around the pivot at the actual shoulder. So that's the action of the deltoid. If we look just for a moment at the adductor, some of the adductors, we've talked about the abductors, now talking about the adductors, and three of them are attached here in this area around what's known as the intertubercular groove. We've got the greater tuberosity, where the supraspinatus attaches, and we have the lesser tuberosity, that we'll talk about that in a minute. Between them is a groove in which the long head of the biceps runs. And at this groove there's three attachments here. Pectoralis major is the most lateral, and that's a powerful adductor as well as internal rotator of the humerus. At the floor of on the other lip of the groove we've got teres major, another adductor, and in between those we've got latissimus dorsi, which lies between these two majors, a lat between two majors. If we now go to the top of the humerus and talk about the rotator cuff, so subscapularis, this muscle that lies underneath the scapula, against the blade of the scapula, attaches to the lesser tuberosity and forms the anterior wall of the rotator cuff. As we go over the top, the superior wall of the rotator cuff is made by supraspinatus that we referred to earlier. And if we now turn and look at the other side of the humerus, we can see the rest of the rotator cuff, the infraspinatus here at the top, and then below that the teres minor. We've looked at the role played by the deltoid in abduction, that it's a powerful abductor from about 30 degrees of abduction. But it can only
lift the humerus up till it's at its maximum shortening, which is when the arm is more or less horizontal. Any further movement raising the arm higher than the horizontal requires scapulothoracic movement, and that's what we'll show here. And this is that the scapula is then rotated on the thorax by the action of the trapezius. The trapezius, if we remember, has fibers that run downwards from high in the neck, so the trapezius acting on the more lateral aspects of the spine of the scapula. And the serratus anterior, this muscle which wraps round the wall of the chest just outside the ribs and then attaches on the free edge, the medial edge of the scapula. This pulls the lower part of the edge of the scapula forward while the trapezius lifts the spine upwards and medially, and that creates scapulothoracic rotation.
Okay, so that's just a quick summary of the movements of the rotator cuff and the various muscles involved. And I'm going to move on from there to look at the axilla. So this is a picture of the axilla, and the axilla has anterior wall, posterior wall, medial wall, and contents. So the anterior wall is mostly made up of pectoralis major, but also pectoralis minor, which isn't shown in this particular section. This image is from quite high up in the chest. And then the posterior wall has got the scapula in it, but also latissimus dorsi, subscapularis, and the most inferior muscle, the free border at the back of the axilla, is made up of teres major. And then after that, if we look at the medial wall of the axilla, it's made up by serratus anterior. So here's serratus anterior attaching to the free edge of the scapula, coming round the ribs, and as it pulls forward, being responsible for that scapulothoracic movement that we need for full abduction. If we look then at the contents of the, let's just label up these muscles. If we look then at the contents of the axilla, we've got the axillary artery, the veins that run with that, and then around the artery we've got the brachial plexus. We've got the cords of the brachial plexus, which are described medial, lateral and posterior with respect to the axillary artery. And then these green structures that I've labelled here, that I've noted here, are lymph nodes, which of course there's groups of lymph nodes within the axilla. Okay, so moving from the axilla to another important clinical issue in this area, and that is what's known as the safe triangle. And this relates to the insertion of chest drains. So if we're going to put a chest drain in, we want to avoid important structures. We want to be as safe as we can. So we want to avoid the diaphragm, we want to avoid important nerves and so on. And of course, when we put a chest drain in, we're going to look for a position just above the rib below, because if we get too close to the next rib up, we may hit the intercostal vessels where they run just underneath the rib above. So we always go just above the rib below. But we also should go within this safe triangle. And so the safe triangle, the anterior border of it, is the edge of pectoralis major, the lateral border of pectoralis major. The back of the triangle is the mid-axillary line. So if we remember, with the serratus anterior, we have the long thoracic nerve, and we're trying to avoid that. So we keep anterior to the mid-axillary line. And then the floor of the triangle is a line at the fifth intercostal space level, and that's so that we don't go too low and risk going into the diaphragm and hence potentially into the liver. So that's the safe triangle for chest drain insertion.